Okay, good morning. My name is Benjamin Abraham. I'm a staff anesthesiologist at the Cleveland Clinic Foundation in Cleveland, Ohio. What I wanted to talk to you guys today was about pain and pain management, specifically how this relates to lab medicine, family medicine, primary care, and a varied number of fields. So firstly, I wanted to let you know that I have no financial disclosures to report. What I intend to do here for the talk is first define pain. We also need to identify who is affected by pain. It's a surprising number of patients. Second, I wanted to talk about what the treatments are, what the treatments were, and specifically what challenges relate to lab medicine and pain management. One of the things I mentioned was the collaboration seems to be more and more important as we move forward. I wanted to also mention that if there are any questions throughout the talk, please feel free to enter those in. I can address those at the end of the talk, but I'll have a running tally of those in the meantime. So firstly, what is pain? The word itself is derived from the Greek, meaning penalty or punishment. Now this tells you something in and of itself. This tells you that how pain was thought of in the past is very different from how it's thought of today. We know this by looking at older artwork. A great example is Michelangelo's The Last Judgment. You can see here that in this painting, it's actually the devil or devils who are inflicting pain on people depicted here in this picture of various kinds. There's some thinking that in the bottom right, this is gout, as evidenced by the demon twisting the big toe on the person in the corner. So today we define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Now, this is universally the accepted definition of pain that pain management specialists are using. A few things to note here. The definition begins with sensory and emotional experience associated with this pain, whereas we used to think of it as simply biological damage causing neuronal firing. That's not so much the case anymore. So when we talk about pain, the first thing we need to know is whether it's acute or chronic pain. It could be surgical or non-surgical pain. It could be malignant pain or benign pain. Pain management doctors and those that refer to pain management doctors will need to identify, is there underlying disease? Has that underlying disease been treated? We also are interested whether it's continuous, episodic, is it localized? Is it all over the body? For those of you in the audience who are clinicians, we know that there are a large number of patients who complain of pain everywhere. This is what a lot of primary care physicians refer to as the doorknob question. As soon as the visit is over about their high blood pressure, often patients will report by the way, I'm having pain all over. Can we talk about that? So here you have a descriptors drawn by patients. These diagrams are, in some cases, pathognomonic for the conditions that they are associated with. On the left, you have a patient who we see quite a bit of, a disease called fibromyalgia. On the right side of your screen, you have a patient with a neuropathic pain process. And again, how these patients are describing their pain, how they're drawing it, really has an impact on how it's managed, what laboratory testing is involved, and what their treatment it will be ultimately. There's a big influence on how they're perceiving their pain, how they're drawing their pain, and ultimately what their outcome is going to be. So there's some disagreement about what is chronic pain. Chronic non-cancer pain in some circles is defined as persisting 6 months or greater after an injury. Some physicians will talk about chronic pain being after 3 months. We know that chronic pain is persisting beyond the usual course of active disease. So for example, a rib fracture, after the rib heals and the patient continues to have pain, we would consider that to be chronic pain after 3 to 6 months. Often we notice that the pain is associated with pathological processes, not only limited to the biological damage that may have been done. It could last for months or years. In many cases, fibromyalgia is a great example, we may not even be able to demonstrate the pathology via lab test imaging. There are some cases where routine pain control methods such as physical therapy, activity modification, anti-inflammatory medicines have no effect. And the surprise to many patients is that healing may never occur from whatever this process may be. These definitions were developed by the American Society of Interventional Pain Physicians, and like many other fields such as neurology, pathology, there are many different opinions about the contents of this slide. One thing that's pain physicians do agree on is that chronic persistent pain has effects not just on the biology of the patient, not just on the neurons, not just on the bones or muscles. We know that there's significant impairment of physical, psychological health along with biological changes that may have occurred. We also know that there's impairment of social responsibilities. Patients may leave work. Patients may have marital problems, divorce, as a result of their pain problem. So one of the things that we've come to realize is that recognizing all these factors, the social, the psychological, as well as the biological, are combining to be necessary in order for us to effectively treat these chronic pain patients. It's now recognized that what we call multidisciplinary pain care, this is the new standard. Whether you're an interventionalist, whether you do pain management with a background in psychiatry, whether your background is in neurology or neurosurgery, this remains something that most, if not all, physicians agree on. So William Osler made a great point. In order to treat something, we must first learn to recognize it. Something that's germane to this topic is there's no lab test for pain. There is some research going on now that looks at fMRI, but there is no simple, established, definitive test for pain, whereas there might be for cancer, there might be for hypothyroid. The question is, how many pain patients are floating around in the ether here who also are having psychosocial dysfunction? Many times, a large number of these patients either don't discuss it with their physician or aren't receiving standard of care treatments for readily identifiable problems. So the first question is, how common are these conditions when we compare them to diabetes, cancer, heart disease? The answers might surprise you. When we look at Institute of Medicine report done in 2011, we see that chronic pain actually affects 116 million Americans, whereas cancer, the totals are 11 or 12 million. This is not this is a trend that has continued, and in fact, chronic pain as a percentage of the population is actually increasing at a dramatic rate. So 116 million Americans, let's look at what exactly that number means. Let's look at the population of India and the US. There's a big difference there. Let's look at the population of the US compared to those who may be in chronic pain. We see that the number of Americans who are affected by chronic pain is actually close to the population of Mexico, somewhere between the population of Mexico and Japan. This is startling. So within the United States, we have essentially a whole other country of patients within our borders who are chronic pain patients. So why would this matter to those who are in the lab? Why would this matter to primary care physicians in the clinic? Why would this matter to chronic pain physicians, anesthesiologists such as myself? This is turning out to be one of the largest public health issues in America. I'm sure that you've seen in the news that application for disability, they are increasing at an astronomical rate. We know that this is costing the U.S. somewhere in the neighborhood of 500 to 600 billion. Out of your own pocket, about $2,000 is coming every year. So all these facts are interesting because we do know, based on radiological studies, those done by Jensen, those done by Rathmel, we know that over time, as patients age, the amount of back pain that they actually have decreases. If you look here at the diagram, you'll see that there's a peak at around age 40 or so, and it steadily declines thereafter. We notice that despite the radiological changes that may increase, for example, the older patient in their 80s or 90s may tell you that they are having claudication symptoms, difficulty walking, but often they'll say that they don't really have much back pain. So this is one of the challenges of treatment. Why has pain increased? More specifically, back pain has increased dramatically in the last few years. Along with that, our challenge is to treat these patients. So some of the challenges that we face as clinicians, these patients seem to have a higher than expected non-compliance rate. This non-compliance rate is manifested in no-show visits. It's manifested in non-concordant ear and drug testing. It's also manifested in compliance with medication treatments. Here's an example from my own clinic, actually. This is a patient who no-showed 8 times in 3 months. Now, these are visits that, after each no-show, the patient made the appointment again. So they actually had to call in to the scheduling office, make another appointment. This proceeded 8 times in 3 months. Now, this would give you some idea that there are a lot of other psychosocial issues going on here. Something pertinent to this topic today is that these patients have a large percentage of them, larger than expected, are using illicit drugs. We actually found that around 15% of chronic pain patients, when we are to check their urine or hair or blood, we find illicit drugs in about 15% of patients who are not prescribed controlled substances. An effect that is unclear as to why. We actually find that 34% of these patients who are prescribed controlled substances are found to have illicit drugs in their urine. An area of great debate is, what effect does random drug testing, prescription monitoring, pill counting, so-called adherence monitoring, what effect does this actually have on outcome? This is an area of great debate now. we've actually found a decrease in illicit and controlled substance abuse, but it has had no effect on patient compliance. When we look at the data, when we poll these patients anonymously, we find that most often these patients are, quote unquote, borrowing medicine from family members. The second most common is purchasing these medicines from family members or friends. And this data is readily available on the CDC website. It's startling, to say the least. One of the things that has popped up in the internet age is online marketplaces. Many of you have gotten the spam emails for buy a Viagra now without a prescription, buy Vicodin now without a prescription. And surprisingly, these links actually work. Hopefully none of you have clicked on them, but what we've learned from drug rehabilitation patients is that these medicines are readily available if you reply to these spam emails. They're available for inflated prices, but you don't really need a prescription. Something interesting that was recently discovered was a website called the Silk Road. This website has exchanged hands multiple times since the arrest of its founder. And those of you who are movie buffs might recognize the name the Dread Pirate Roberts. The administrator of this website, this illegal online drug marketplace, actually passes the torch to the next person without ever revealing their identity. When we look at who is prescribing these medicines in the legal setting, we see that there are many contributors, but primary care physicians, the gatekeepers of the patients, seem to be the largest contributor, and they represent the highest number of prescriptions per year. When we talk about addiction, we're finding that based on CDC data, we're having 2% of patients are self-reporting abuse of prescription drugs in the last month. CDC data also, in some studies, is finding that between 3 and 16% of the U.S. population, and we're talking about illicit drugs, prescription drugs, are affected by addiction. So the question is, to understand how we're doing things now, how was pain treated in the past? Going all the way back to 300 BC, we know we have descriptions of the medicinal effects of the poppy extract. Morphine was isolated and purified in the 1800s, injected later on in the 1850s. So some terminology that's important for this discussion is, let's first talk about opioids, natural or synthetic compounds that bind to the opioid receptor. Simply put, opioid analgesics differ from opioids in that they're opioid receptor agonists that relieve pain. There are many anti-diarrheal agents that are opioid agonists and yet have no pain-relieving effects. These are separate from local anesthetics. These are separate from anti-inflammatory medicines, both of which may relieve pain but aren't considered opioid analgesics. One important thing to note is that narcotics is not a term that is usually used in the medical parlance. So how is pain treated now? Pain's treated now, as I mentioned, through a combination of psychological treatments and biological treatments and social treatments in some cases. I myself was trained as an anesthesiologist, a general anesthesiologist, went on to complete fellowship training in interventional pain management, which includes neuroablations, spinal cord stimulation, procedures essentially to supplement our arsenal of medications that may treat pain. When we talk about non-interventional treatments, we're referring to anti-inflammatory medicines, physical therapy, activity modification. when we talk about cognitive behavioral therapy and psychological treatments, often the assistance of a psychologist or a psychiatrist is required to address comorbid depression. Often there's psychological dysfunction. When we bring the families in to enhance accountability for these patients, we actually find outcomes are improved. So what has the research shown us thus far? We know that despite hundreds and hundreds of years of using opioids, we know that only some patients are achieving functional restoration with opioid therapy. There are many who do not. Why is poorly understood at this point. However, there are unavoidable side effects that we know to be the case with these medications, especially when they're daily medications, especially when they're used long term. We know that there are changes in hormones, pulmonary mechanics, sleep architecture. Our colleagues in neurology discovered the vast number of effects on sleep architecture using EEG recording. We also know from lab testing and research studies that pain processing has changed, perception has changed. A phenomenon that was recently discovered is something called opioid-induced hyperalgesia. Simply put, this is more pain with chronic treatment using these medications. So one of the guidelines that many physicians are using, and some would say it's a common sense guideline. These medications, such as opioids, are being used now as if they were a medicine like warfarin, a blood thinner. Physicians are asking themselves, would I do this, would I prescribe this medicine if this patient were on warfarin? For example, would I prescribe hydrocodone if the patient was already on oxycodone? Would I perform a surgery without a discharge plan for the patient's warfarin, or in our case here, a discharge plan for the patient's oral opioid therapy? We know that surgery and postoperative pain is increased when the patient comes in on chronic opioid therapy. Analogous to warfarin, we're often needing to check the PT and the INR. The same goes for these medicines such as hydrocodone, oxycodone, etc. We need to monitor them. We need to monitor whether they're actually in the patient's system. Are there other substances that may be interfering? Often clinicians are asking themselves, would I begin another therapy such as hydrocodone and just assume that another physician would be taking that over? Often this is overlooked. Analogous to warfarin, many clinicians are asking themselves, would I add an antiplatelet agent if the patient was already on warfarin? Would you add a second opioid if the patient is already being prescribed an opioid? This is taken directly from the DEA website, who issues our licenses to prescribe. We know that we're expected to follow the guidelines that they set forth, though many clinicians aren't aware of what those actual guidelines are. Essentially, you're responsible for all federal and state regulations regarding these controlled substances, whether you know it or not. You're responsible for patient evaluation. Many of the cases you see in the newspaper of physicians being arrested are due to lack of evaluation. Secondly, they may be due to lack of evaluation, physical exam taking, trialing of conservative therapies. This is an important aspect of the treatment of these patients, is that trialing non-opioid therapies. Patients also need to be screened for substance abuse, and this is where laboratory testing is essential. Most patients will not be forthcoming with their substance abuse if you're also the person writing their controlled substances. In Ohio and throughout the United States, we have a prescription monitoring system, the Ohio Automated RX Reporting System. This is mirrored in many states, though it's not universal. Many states do not have it in the U.S. One of the critical aspects of treatment of pain patients is identification of what the treatment objectives actually are. Some patients may expect 100% pain relief. Some patients would be happy with 10% pain relief, but not having a goal in mind really sets you back. One of the things that many facilities are doing now is informed consent, making sure that these patients are aware of what are the risks for opioid therapy. As the rate of accidental overdose rises, patients seem to be just as ill-informed as they were in the past, despite the newspaper headlines. So, as I mentioned, patients are having changes in pain processing. Patients are having changes in pain perception. Patients on chronic opioids oftentimes will have changes in their cold pressor test, their ability to tolerate an ice water bath on their arm, for example. And this can be tested in the lab and is readily able to be demonstrated. So what's changed? Why are we doing things differently now? Often, it's not, as is the case, it's not a change in the science necessarily, it's a change in the medical licensure. So you may have heard that now there's a backswing, whereas overprescribing was the case perhaps 10 years ago. Now it may be underprescribing again, quote unquote. Now at this point, overprescribing of controlled substances is the leading cause of investigation and discipline for state medical boards. So whether you're a primary care physician, the writers of the most opioid prescriptions in the United States, or a pain physician, or a neurologist or a psychiatrist, these are relevant issues if you're seeing patients in the clinic. One thing that is important to note is that state medical boards often aren't populated with experts in laboratory medicine. They aren't often populated with experts in pain management or addictionology. Often, physicians are disciplined in states around the country despite expert testimony. So this graph is very telling. You'll notice the trend at the top. There's pretty much a steady increase. In 2006, for example, to use Ohio as an example, there was 183 disciplinary actions, whereas in 2011 the number is 217. Now, you might say, well, what happened in 2011? There was a bill called House Bill 93, which greatly changed the regulations surrounding prescription of opioid medications. If you look down at the bottom, you'll see that prescribing issues actually jumped from 6 to 38 as the reason for disciplinary action. So the question then is, what are the state medical boards using to guide their decisions? One study looked at the state medical boards and actually polled medical board members in various states in the U.S. Asked about firstly their demographics, what their knowledge was of the actual federal and state laws, and what were their clinical beliefs. So, strangely, 37% rated their own training in pain management as excellent or good. Along similar lines, 22% rated their training in addictionology as excellent or good. However, only 25%, a quarter of the board members whose training was excellent or good as they rated it, only 25% could correctly define addiction. 13% thought they knew what the accepted current definitions of addiction were, but were incorrect. So while addiction, iatrogenic addiction to opioids is fairly low when it's used to treat chronic non-malignant pain, non-cancer pain, 46% of state medical board members actually believe it to be a common occurrence. In fact, 91% believe diversion and abuse were a problem in their state. Whether this is related to politics or not is unclear. So these results should surprise you. So what do we know about dependence? We know that dependence is a maladaptive pattern of substance use leading to impairment or distress. It actually requires tolerance, withdrawal, taking larger amounts than is intended. Also, it requires the desire or unsuccessful attempts to cut down. And this is from DSM-4. Substance abuse, again, is a maladaptive pattern of substance use leading to impairment or distress, requires within the year recurrent issues fulfilling major role obligations, so work, school, situations where it's physically hazardous, legal problems. To summarize, a patient has an addiction with compulsive use despite harm. This is the sort of one-sentence summary here. It's important to note that the DSM-4 doesn't talk about addiction. This is not a defined diagnosis in the DSM-4, nor is it in DSM-5. So while a notable proportion of state medical boards don't recognize the legal acceptability of chronic opioid therapy, state guidelines in place in these very same states support and encourage the use of chronic opioid therapy for non-cancer pain. In fact, you may have noticed court cases where the undertreatment of pain was actually found to be malpractice. So while 80% of board members believe that the state policies for opioids and opioid regulation was useful, only 43% actually knew the laws. So for example, 27% thought that physicians who aren't addictionologists could write for methadone for chronic non-malignant pain. The fact is that anyone with a DEA license to prescribe scheduled medications can write for methadone if it's for the treatment of pain and not for opioid addiction or detox. Also, only about half of the board members knew that there was no limit on the quantity of opioids prescribed at one time. So more than a quarter would doubt the legitimacy of a physician writing for more than one opioid at a time. We know that often patients are prescribed long-acting and short-acting medicines at the same time. The evidence for this is not settled by any means. Whether this is medically justified or not, we don't know. But we do know that it drastically increases the risk for accidental addiction. So we do know that board members who discovered or who defined addiction incorrectly were also the same physicians who were likely to review chronic opioid therapy for non-cancer pain as unlawful or unacceptable. What we do know is that the opioid prescriptions despite evidence of harm, are increasing in their use for chronic non-cancer pain. We know that opioids aren't effective in many cases. We do know that there's a lot of uncertainty regarding the long-term benefits. This is largely due to the fact that many of these controlled trials, if indeed they are randomized controlled trials, many of them have a very large dropout rate. So one such meta-analysis looked at 70 randomized controlled trials looking at the benefits versus harm of chronic opioid therapy in non-malignant pain. And indeed, most of the trials were less than 16 weeks long. Unfortunately, and this is often the case with developing a randomized controlled trial, is you have to exclude the high-risk patients. You have to exclude patients with psychiatric comorbidities, whereas often these are a large percentage of patients who are in the clinics, whether it's internal medicine, neurology, headache clinics. We do know that there's little to no evidence for chronic opioid therapy in low back pain, and yet in many clinics this is the most common use of these medications. As you can see, there's quite a research gap here. We know that a lot of these guidelines, as a result, were developed by expert consensus. They weren't necessarily randomized controlled trials, as would be the standard for many other treatments in many other fields. So 37 critical research questions were identified by the American Pain Society and the American Academy of Pain Medicine. That should suggest to you that there's a large need for ongoing research. One of the attempts to classify who should be receiving opioids examines the diagnosis, the intractability of the patient, of the pain, the reliability of the patient, and the efficacy, the effect of these medicines on patient function. Despite research into this area, despite these guidelines, the evidence for chronic opioid therapy remains scant. We know that we have far greater, much more solid evidence for non-opioid interventions to treat chronic non-cancer pain. So let's talk about drug testing. When we looked at internal medicine, we know that internal medicine residents often are reporting high confidence and yet low knowledge scores when actually examining the interpretation of urine drug tests. So when we looked at objective measures of urine drug testing, we found that 99 residents, for example, scored a 3 out of 7 on this test. It's a 7-question test regarding their objective knowledge of lab testing in regards to compliance for these patients. We did notice that there's a significant difference in male versus female residents. We did know that their confidence score, as their confidence in their knowledge increased, their scores actually decreased on objective testing. So what do we know? We know that chronic pain is now the #1 most common condition in the United States as far as medical diseases go, if we can call it a single medical disease. It remains one of the most challenging to treat. Since 2008, and indeed before that, it's the most common source of disability in modern society. So effective treatment of this population is going to require marshaling resources from laboratory medicine to help educate physicians such as myself in pain management, internal medicine, neurology, and psychiatry, psychology, in order to monitor compliance, in order to prevent accidental overdose and maximize benefit if indeed controlled substances are used in these patients' treatments. So I'd be happy to answer some questions, if there were any. Well, I'd like to thank everyone for participating, and enjoy the rest of your day.